our speaker today, Jessica Zan, is a nurse and is also, we always start with that, most important, credibility, and vice president for clinical implementation and success at MyDirectives. So she is really an advanced care planning and ACP subject matter and supports MyDirectives. She talks a lot to customers and is really interesting because she looks at workflows, training, guidance, technical consideration. I've talked to Jessica a couple of times, and I'm really glad that she can speak to us today because she brings a lot of expertise to this question of how do we find those ACP documents. I really appreciate that we started this with a POLST conversation and then has expanded into advanced care planning. And Hope actually used MyDirectives many years ago. So we've known about you, but we're really glad that you can talk to today. Also important to say that Jessica is an ACP innovator and did a groundbreaking program with a major health system where she lives in Oklahoma, which has led to a leadership role with Epic applications. And then now she's at MyDirectives. And as I shared with you, most of our health systems use Epic in the state. So she brings a unique blend of clinical nursing expertise, a passion for advanced care planning, and IT proficiency to speak publicly about successful advanced care planning and help health systems develop robust advanced care planning programs that prioritize patient-centered care. So Jessica, thank you so much for coming today, and I'll turn it over to you.
Thank you. I am so excited to be here. So thank you. My gratitude to all of you for the generosity of your time and your interest. And I want to say at the top, there are going to be some moments during this presentation where I am 100% preaching to the choir. If you showed up to this conversation, you already know the things that I'm presenting. The reason I'm presenting them in this sequence is because all of us know how long we've seen the problems. And it's going to take all of us organizing our voices around the conversations, the solutions to help get over the hump of those problems. So I don't mean to be redundant for you or to diminish your knowledge. I know you have it. I am just getting the opportunity with my colleagues to figure out how do I navigate helping people who are less interested or even not interested in advanced care planning recognize what a critical portion of the healthcare experience that it is. And so some of these come from that experience. So I did bring some buddies with me today. I am Jessica Zan. You've got to hear way too much about me. Mike Munoz is our Chief Product Officer. He has been with MyDirectives for around 8 years, and really a lot of the technology solutions that you're going to see throughout here, which are the reasons that I left my kind of stable healthcare institutional typical job. Um, Mike designed those. He facilitated those coming into being. So I can't give enough gratitude for him. And when technical questions come up, you're going to hear me rely on him. He and I have a kind of dog and pony show that we do where we catch up for each other. So he'll jump in and let me know if I've dropped something or forgotten it. And then we also have the privilege of having Joanne Eason with us today. Joanne is our senior advisor for business development. She's formerly the president of Five Wishes. So Joanne, I don't think anyone on the call can feel shy about recognizing that Joanne has had a dramatic impact on the state of advanced care planning in the US through the Five Wishes and the patient-centeredness of that document. It's such a beloved document, and we're really glad that she gets to be one of our senior advisors now. So I'll jump in. And again, this is the redundant part. This is the part we all know, but what a lot of us that care about ACP don't know is that last year in June, there was a research article that came out in the Journal of Healthcare Economics. And for the first time, somebody designed a study that was kind of impossible to dismantle. So this study looked across tens of thousands of Medicare decedents over the last year of life after an index unavoidable ER visit. And it took that population of thousands of CMS decedents and broke them into categories of has ACP, did not have ACP. And the findings solidify what we all know, that when individuals get the opportunity to record what they want, by and large, we know folks don't want aggressive interventions to undo what cannot be undone. And this study was able to actually put numbers and dollars and cents to that. For instance, 21% decreased likelihood of dying in the hospital, 24% decreased inpatient spending, 17% lower spending overall, 18% increase in use of hospice, and a decrease in ICU utilization in the last days. One of the reasons that this slide is so important to me is because when I am helping folks understand where ACP sits for a long time, we've known it's the right thing to do, it's the compassionate thing to do, it's the kind thing to do. The conversation needs to also be that it is a necessary part of how we do healthcare because every dollar and every day saved in this slide was not about withholding of care. It was about providing the experience that an individual wanted instead of giving to them a journey that did not align with their values and wishes. But for far too long, ACP has been a broken promise. I mean, all of us that have done clinical ACP have gone through the experience sitting down with an individual, facilitating them through more or less complex documents, coming out with a legally valid document, and we find out later that patient still died an incongruent death with what they wanted. I personally have had patients that I facilitated a do not resuscitate order when they left the hospital to go to a skilled facility. That document did not travel with them, and they subsequently received resuscitation attempts counter to what they expressed that they wanted. And then not only is there the abuse and the trauma of that, there's also the downhill effect of having an unexpected readmission and an unexpected mortality, the burnout and compassion fatigue that lands on the shoulders of the clinicians who find out after the fact that this is how this story went despite our best endeavors. So we know that ACP for a long time has been this kind of broken promise. You fill out this document, it'll protect you when you can't communicate for yourself anymore. But far too often, there are studies that show how often documents don't show up at the point of care, even when they're created. And we know that at large, Americans still don't fill out a lot of advanced care planning to begin with. Sometimes those documents are in the health system's records, they show up, but they're completed incorrectly and they lose their actionableness. Or, particularly with portable medical orders, they may have incongruent choices because they were done on paper. So there were no rules to say you can't pick this choice and this choice, those two aren't medically compatible. And then often, we get everything right. The document shows up at the point of care. It's completed to the nine. It's perfect in every way according to state regulations, and nothing in the electronic health record is causing a provider to view that to support the medical decisions that need to be made. In my view, advanced care planning is the last intervention in healthcare that we are still holding on to paper as a solution when technology has been used to hold on to the digital integrity of every medication a patient has ever had. I can go to the HIE and find out about their notes across visits. I can find their blood pressures across health systems. We need to start bending the same digital integrity toward their wishes and their values and their statements of what they want from healthcare. And that infrastructure is possible. And we're actually doing this as a state initiative through MyDirectives, and that's what I want to spend time talking with you about today. So the solutions that we offer, I'm going to break them down little by little. This is my first chip at that. We have, if for standardizing conversations with people, because advanced care planning, I don't ever believe will become something that is fully automated. It's far too human, far too nuanced. Well, one of the things that we can do to increase the quality and the repetition of high quality conversations is using online tools or digital tools to complete the documents. And we've designed that in the clinical setting with an app called MyDirectives for clinicians, and I'll show you more later. Also, that problem that we talked about in the broken promise, where documents don't show up. Somebody at one health system has got that done and it's in that epic, but it's not in the epic down the road. And so that document doesn't protect that patient when some sort of necessity takes them to the next facility. Well, we have designed a nationwide registry that we call the AD Vault Exchange. Also, when states are taking that initiative to say advanced care planning matters to us, not just us as healthcare workers and representatives and advocates, but us because we also are or will be patients. We want to prioritize the voice of the human in the center of the care. We have reports and analytics to make sure that as those initiatives are being taken, you've got quality insights that you can use to iterate, improve, try again, do more, understand what's working, and so on. And then we also make sure that no matter what happens, there's always access for those documents, either to be created or, if created in a clinical setting, to be sent back to the patient, because at the end of the day, those are patient documents. They reflect that individual and they need to have agency over what happens with those documents. And we have a solution for that as well. And then what my department supports is how the engagement around the state is warmed up, how the state works together to design clinical workflows, increase awareness, drive engagement to make sure that the technology is not dead in the water. It could be the best, most elegant technology. If nobody's touching it, it's not changing lives. And that's not what any of us want. So we want to also give supports for that. And uh, one of the reasons that we talk about this from the level of a statewide ecosystem is because healthcare is interested in advanced care planning. There's no doubt about that. It's not the top priority in every place. There are lots of places that are prioritizing it higher than others, but it's not being driven with the same kind of statewide energy, certainly not the same kind of federal energy that a lot of different health initiatives and endeavors are having. But when you have smart technology and you have everybody pulling in the same direction, you have a higher rate of document completion. That higher rate of document completion means there are more documents to be found at the point of care. Finding those documents at the point of care is what drives down those unwanted interventions, those wasteful interventions that are diminishing quality of life in the last days for so many people. And of course, CMS is taking a big interest in this. It's kind of popcorn, every once in a while they'll say it's a requirement for this kind of payment model. It's not for that one. And it comes and it goes. But when you look at the age-friendly health systems model that CMS is putting into place as of this year, ACP represents the patient's wishes and goals and preferences for care, which in some settings is called what matters most. So it's the recognition, even at the federal level, that these are the kinds of conversations that improve our whole healthcare ecosystem, that can be taken to have the same advantages for the state when the state is pulling all together. And I've got in this picture here kind of a hub and spoke model. What we have found for some states, and it's not this way for every state, but what we've found is that our centralized repository, the AD Vault Exchange, becomes connected to the state HIE, which then becomes kind of a pass-through for documents that are being done out in those spokes at the health systems, at the clinics, in the community settings. As those documents are being stored in the AD Vault Exchange, when that patient transitions to another point of care, that document is going back out wherever that is. So we have, we believe, designed end-to-end advanced care planning. And this is my favorite slide to represent MyDirectives technology solutions. We have first more mechanisms for creating digital documents. So we have MyDirectives, which is available if you were to go right now, like Hope has done, to mydirectives.com. You'll find there's a button that allows you to log into our application, build an account, complete your advanced care plan. If you already have one that somehow has been linked to our accounts, you would find it in there. But patients are able to create a number of advanced care planning documents in there, but doesn't stop there. Is most ACP in the US is completed in a facilitated setting, whether that's with a clinical person or a volunteer or in the community. What we've designed to facilitate that is MyDirectives for clinicians, and that is a lovely application that's available in two different ways that I'll get into further. But what's so important is that these two have been designed to be in dialogue with each other. A lot of times in my experience when I was doing advanced care planning with folks, I would create the document, I would give the original to the patient. After I'd made a copy, I'd scan the copy in, get it to somebody who was qualified to scan it into the electronic health record, and I would hope, against hope, that they scanned it in appropriately. But if that patient went home and did another ACP because they changed their mind with a doctor at a different health system, there is no dialogue between all of these moving parts. So we've created an instantaneous dialogue between the patient and the clinical side so that there's never a story where somebody has something that the other party doesn't have. And that solves some of the problems in the broken promise of ACP, but it doesn't solve for all of them. There's a lot of solutions for advanced care planning interventions stop in that blue line. What we created next is what changes the whole game. Because not only are those documents being created and shared intermingly between each other, they're also being stored in the AD Vault Exchange. Right now, that exchange is tethered to several state HIEs. For several states, we are the repository for that HIE. It's also tethered to the national data exchanges. And from one national data exchange alone, we are being queried to the AD Vault Exchange for ACP documents over 1 million times a week. And that's before every health system in the US even knows that they can turn on ACP as a response when they're querying for documents and medical history on their patients. So going back to that slide about the statewide ecosystem, imagine the power of everybody in the state feeding into the same source and retrieving from the same source. And what we have seen for some states that self-create a repository is that it's just an empty bag and it can be filled, but often it has to be filled in a separate experience that is paper-based. And then either the patient or the clinician has to have the credentials to be able to put the document in. And then whoever needs to retrieve it has to know that they can retrieve it and they have to have the credentials to do that. And they kind of become sleepy. They're well intended and well designed, but the elegance of this design is that the mechanism of creating the document is the same mechanism that stores it, which is the same place we're going to retrieve it from when that patient goes down into a condition where they're going to need that document to represent them. And that is what we work on the digital retrieval side. What's really cool when we're doing a statewide initiative is that we're able to also work with EMS. Imagine a POLST, right? The POLST is designed to protect somebody who is seriously ill or who is at risk of having multiple emergent events, and an advanced directive doesn't cover their acute now. They haven't lost capacity. They may not be irreversibly ill, but they still have capacity until these acute events happen, and the POLST protects that. But if that POLST isn't available in the community setting, it's not protecting people where they live. So working through the retrieval mechanisms that we have to make sure that not only do hospitals and doctors and clinics and palliative cares have access to the documents, but so does EMS, can radically change how patients are being protected and represented in their lived environment. And because it's all digital, we can give you all kinds of data about what's happening at the state level. You can get into a system and see who's doing the most ACP. How long is it taking to do ACP? What documents are being completed at what rates? So I got a little bit ahead of myself, and normally I start with this slide, but I wanted to give you all of those pieces before I got here because this slide is why all those other pieces have happened. One of the things about us that's different is that we've been doing digital ACP solutions for 18 years. That time exploring, experimenting, studying, getting it right, getting it not as right, all of that has led to what I believe having experienced healthcare and ACP not working when it was supposed to. I think that's why we have a promise that we can actually start keeping through the good technology. We are functional everywhere. We have users all over the US and some outside of the US as well. And we are, of course, in healthcare, we're HIPAA compliant, but also ACP documents sit in kind of a gray zone where they have to be protected as patient private health information, but they have to be largely retrievable because if they don't show up at the point of care, they don't exist and they don't drive care. So we have taken a lot of extra steps to get extra certified for our security mechanisms so that people can feel confident in letting documents be with us. We've learned a lot from some premier partners who have helped us grow and helped us become more relevant in the spaces that we serve in. And we've partnered with some of the best people in the country. We are the only digital partner for Five Wishes. So for those of you who like that document, if you want to do it digitally, we actually serve up the technology for that. And we are also partnered with the National POLST Collaborative, which of course is how I get to spend time with Jeanette every once in a while. So we've been able to use their best practices and guidance as we've built out our interface. We use modern technology. In fact, we've shaped modern technology with some of my colleagues who've gotten to sit in at work groups with CMS, defining the codes that break down how the data about advanced care planning is interoperable across systems and EHRs. I've already shared with you about the national data exchanges. And we've also worked really hard to integrate into electronic health records. Those of you who work in EHRs know that if something you have to leave your EHR to go do something, it's going to be at the bottom of your priority list. So trying to make sure that clinical folks have access to do documentation where they do their documentation is one of our top priorities. And then we work hard to make sure that EMS and 911 have access to the documents that we have in our system so that that can change emergency treatment in the clinical setting. So, talking about accessibility and interoperability, I've mentioned the AD Vault Exchange, and that's the hub of the whole wheel. And that's the part that we tether to national data exchanges, to HIEs, to make sure that our documents have a mechanism for getting back out to organizations, some of which have no relationship with us at all. And they don't even know they're getting documents from us. But that repository is designed for all of the documents that are created in our system, as well as videos. And we support advanced directives, mental health advanced directives, portable medical orders, DNRs, power of attorney, living will, we'll support it all. So there are a lot of different ways that that AD Vault Exchange provides ACP documents back to the point of care. When folks are using MyDirectives for clinicians, they can have a license to just use the website. So you would type in something like mydc.something.com. And if you've got a license from us, you can log in, you can pull up that patient and see if they have documents on file, and you can create documents with this. The other mechanism for doing that same work with a little bit less pre-work is our EHR integrations. So for instance, if you're working in Epic, we're an integrated app, a validated integrated app with Epic. It feels like you're still staying in Epic when you work with us, and we're able to use really smart technology to pull over the data of who that patient is, match them up with any data that we have, and provide back the details that we have on that individual. We've already talked about EMS and the data exchanges. The only mechanism I haven't talked about is our direct connections. There are some organizations that ask us to basically set up a pipeline to them. They're not sending us documents, but they want to see what we have in our exchange. So we set up a pipeline that allows us to send those documents to them if they have a patient that matches one of our patients in the system. That's the hub. That's where the documents end up. But how the documents gets done is in MyDirectives for clinicians and in MyDirectives. So we'll talk about clinical ACP facilitation. We use standardized documents, and I've talked with Jeanette. I know Hawaii has a advanced directive that Jeanette has had a lot of influence over. We are able to support state level advanced directives, but right now we have two different advanced directive choices. One is Five Wishes, and the other one is our proprietary advanced directive. We're able to put documents into the system that allow a clinical person to get through the primary questions that lead to a medical directive. But then when that document is completed, and I'll demonstrate this for you in a little bit, when that document is done, it looks like you filled it out just as you would have on paper. We have that ability for portable medical orders and mental health advance directives. What's really nice about the system that Mike has spent a lot of energy and a lot of integrity on is making it possible to complete documents without ever lifting a pen or a piece of paper. There's so much time lost in healthcare to printing that document out on the right color of paper, filling it out, getting the demos wrong or putting the wrong answers, starting over, finding somebody to scan it in. You know the footwork and the extra time that goes into that. We're able to really take a lot of that paper burden away. So the focus can be on the quality of the conversation, not the meticulous nature of the documentation. I found a typo that I put in, y'all. We also support video recording, not recoding. I'm not sure what video recoding would look like. Maybe we can support that too. Might put that on the short list of things that we need to be doing. And then anything that is in our system, put into our system, either uploaded or digitally created, is going to go into the 80 Vault Exchange for very streamlined document retrieval. And this is kind of what it looks like in an electronic health record. I have used a generic EHR here because I want you to have the imagination. You'll see the system in a little bit, but the imagination for whatever it is that you use on your daily work, which from what I hear from Jeanette, largely is Epic, um, you're going to be sitting that in our workflows right inside of that. So, speaking about patients and residents having also the opportunity to do that, any advanced care planning initiative that leaves out those folks who will self-complete, self-navigate through ACP is missing an important part of the population. So, we have MyDirectives, which allows folks to self-navigate. We've built in easy guidance, easy to understand guidance. And one of the other things that I like about how this changes the narrative from the paper-based world is it speeds up and makes more ease for individuals who may change their mind. So now I don't have to reprint a whole new paper. I can go in and reversion the document I've already created, get it signed, and that simple adjustment, I've got myself reflected in this document. Also, our system makes it very easy to share. I don't know if you all are familiar with the seagull phrase. The individual that's often from out of state and comes in once everybody's made the decision for the loved one is like, no, that's the person I'm sending mine to. Because I don't want her, I know who she is. I don't want her coming into the unit and trying to put the tube back in for me. So we have the ability for patients to make a lot of choices, use all that agency that they have with just a couple of clicks to get their document anywhere really in the world that they want to get it. And then we are able to support folks putting in paper documents, scanning those in if they prefer, doing paper uploads or videos. And one of the things that's really cool for the state initiatives is that, well, right now, if you all want to do your ACP, if you haven't done it yet, and you go to mydirectives.com and you go to our app page, you're going to see our app page. But what we do when we work with states is we create a custom branded landing page. So it will feel like it represents Hawaii, not just MyDirectives. It'll be both of our stories together. Does a couple of things. One, it helps individuals that are in a region feel more comfortable with where they're landing. But the other thing it does is it gives you data. So imagine that you have that page and you do some sort of email campaign for a certain segment of the population. Have you done your advanced care planning? Go pick your person. You'd be able to see the metrics on the other side of that. How many people clicked on the website? How many started an account? How many started a document? How many people finished a document? So it gives you real-time feedback on the initiatives you're taking. In case you find one you don't want to spend money on next year, where would you rather spend your energy and your time this year? And that's what it looks like on the inside. It's, I'm going to keep moving. So not going to go deeply into our reports and analytics. I just want you to see we can tell you a lot. This is the reporting that comes out of our custom branded landing pages, talking about activity for how many people from your campaign came in through that campaign or that custom page, and what did they do while they were in there? What were their ages and demographics? We are, Mike, do you want to step in and remind me what this one is for? This one's a new one, and Mike has designed it recently.
Yeah, so on the campaign landing pages, in addition to giving you overview information about the traffic and what consumers are doing once they get to the website, we also have the ability to give you detailed information about those users. So if you need specific data about each user, when they created an account, demographic information. We do collect things like race and gender now in the platform. They are optional settings, but we can provide those types of metrics. And then, like Jessica mentioned, we can give you the date that the account was created, the date that an ACP was signed on, whether they did a document upload, whether they shared their document with friends and family, and even information about whether somebody came and actually retrieved or looked for the document on the clinical side. So lots of granular data, and we can define this report based on whatever requirements you have. But this represents the detail if you need it on a resident or patient by patient basis.
One of the things that Mike said right there, he said it so smoothly. I want to call it out. He said, you can even see who's viewing the document. That's the promise kept right there. That's the ACP promise that we all know and have experienced is broken. But when we can put into place metrics for how they're being retrieved and viewed, then we can also figure out how to put in place interventions to ensure that they're being retrieved and viewed at the point of care. And I can tell you about numerous organizations that are doing some very creative designs around that right now. The other thing that I told Jeanette earlier, I'm an ACP geek. Everybody from my team already knew that. This one is a geek thing. Being able to look across the populations who are completing documents and see at what rate are they choosing what types of interventions. Can you imagine the power of that information? That gives us so much insight into what a population around us truly values. And it maybe turns on its head some of the things that we expected. And then these are the performance metrics for the clinical tool. That's where I said you could see which facilitator is out ahead of the bunch and which one is starting a whole lot of documents but forgetting to sign them so they're not complete. You've got a lot of details and information to do quality improvement. So with your permission, at this point, I'd like to give you a brief experience with completing an advanced care plan. Actually, we're going to focus on POLST, but I'll show you a little bit about our advanced care plan as well. And we're going to use my favorite patient. Everybody on my team already knows who it is. This is not a real patient. He came out of my head, so we're not breaking any HIPAA rules here. Where I've landed right now is the place that you land if you're in an EHR integrated experience. So if I was in Epic today and I was going to talk to Woody, I would go to Woody's Epic chart. I would open MyDirectives from there, and it opens to Woody's page based on the technology that Mike has so gloriously designed. And I want to point out a couple of things about this. When Woody, his first introduction to ACP was with me. I'm facilitating it. He does not have a MyDirectives account yet. But when I generated him on the clinical side, we automatically assigned him a username, a unique username. And as long as his email is in the system, we send him a welcome email, congratulating him on working on his ACP and inviting him to get in, look at his documents, share them, and update them as he wishes. The other thing that I want to point out is we also have a patient session timer up here. Some organizations are using that to support the dropping of the ACP CPT billing codes. And some organizations are actually using that as proof of efficiency wins with digital documentation. So that can go two ways. Some people want it to be longer than 16 minutes, and some people want it to be shorter than 16 minutes up there. We'll see right off the bat that Woody has a POLST on file. And because that POLST was created digitally in our system, we're able to take the discrete decisions that Woody selected for his treatments And we're able to bring those out visually before you even have to open the file. And it's a trustworthy process because it's tied to the discrete data. So we know before we've even looked at his pulse that if Woody does not have a pulse, he does not want CPR. If he does have a pulse, he wants selective treatments. But if I'm curious about what he wants for artificial nutrition and hydration, I can open that up and I can see his choice right here. No artificial means. I can also see his signature. And then I'm not a doctor. I just pretend to be one in this system. So you see my signature as the physician with this patient. Woody has also completed a MyDirectives advanced care plan. I accidentally got in and started playing with 5 wishes with him earlier. Normally, you wouldn't see both of those at the same time. But since I have it, well, let's just do this. Okay, when we create advanced care plans digitally, what I've found is often the better an ACP document is for a patient, the longer it is, which is not great for clinical folks. So if you're in the ICU and you're licking your fingertips trying to figure out which page is going to tell you how you respond to this patient in a crisis right now, that's not very efficient. But when a document is created digitally, we can still make sure that patients have that lovely patient experience. But when we render it, the first page becomes about the clinically relevant choices. For instance, who's my healthcare agent? What can they do? And what treatment preferences do I want when I fall into the conditions of an advanced care plan? So all of the rest of the things that Woody has decided are further on in the document, but we've lifted those clinically relevant directives to the first page or the first page and a half. I'm going to go over and I'm going to choose portable medical order. I will tell you, we can support the Hawaii POLST. We have pretty much every state that has a POLST or portable medical order document. We have already designed them. There are some that we haven't because we just haven't had any clients there yet. But today I'm going to demonstrate the national POLST. But even here, Washington, D.C. is actually using 2 different forms. You can see we support multiple forms. We'll select that national POLST. Woody's demographic information was automatically pulled in. Even his location was automatically pulled in. Woody still does not want CPR. But this time, he had chosen selective treatments last time. He's further declined and now he wants only comfort-focused treatments. He continues to not want any artificial nutrition. And here's the first time that we have multiple pathways to complete this document. One, we're going to say that today, Woody is the person who has capacity and is having this conversation with me. I have 2 different mechanisms for getting Woody's signature. One, I can request a remote signature. And this actually works even if the patient's sitting in the room. In fact, one of our largest organizations is primarily using this because the patients don't have the dexterity to use the mouse and their clinicians are primarily on desktops. If I'm on a mobile device, it's pretty easy because Woody would just track in his finger. I can send that request for signature to either an email or to a text message, but I'm actually going to cancel that because Woody has great dexterity and he's signing the document. And again, I'm not a physician. If I were in as Jessica registered nurse, like I normally am, I'd have a selection here that allows me to choose which physician in my system should be signing this document. But today I'm pretending to be a doctor because it makes it faster here. And I'll submit it. And Woody's POLST is done. When I go back to the patient summary page, we'll find that the tiles now look a little different because we've changed those treatment decisions. The POLST itself has the new date, and the previous POLST has been archived. We can retrieve it for view, but when we retrieve it, it's going to be clearly marked as voided. So it's not easy to use the wrong document for somebody's medical decision making. And for those of you guys that are with Epic, I'm going to just share some personal experience here. If you're on Epic, Media Manager is very full of all kinds of documents, some of which are relevant to your patients and some of which don't feel relevant to anything. It can be very challenging to keep track of advanced care planning documents. There are some things that Epic has done to make them easier to find in the code status, But what we find is they often layer up on top of each other. So figuring out which one is the most relevant at any given point can be very hard. With our system, we're able to make sure that only the document that is currently relevant is what is surfaced for that patient. And notice even with this 5 wishes, while it's there because somebody has started something here, it's clearly marked as in progress. This is the one that's complete. I know where I need to cast my eyes to protect this patient. I will quickly show you, I'm going to make a change to the healthcare agent because I want you to see our witnessing opportunities. So I've picked George as the healthcare agent. I've filled in, we always encourage patients fill in as much data as you possibly can. And notice as we're doing that, we have already the opportunity to assign what level of privileges does Woody want George to have access to his documents. So can he see them? No privileges. Can he be told that they exist? Can he see them, or can he also have the privilege to share them? Ideally, George can have them and share them, but I've decided I don't want George talking to a priest. So I'm going to continue. We'll get a little sign here that says you've made a change to the powers that your power of attorney has. So we're going to have a new opportunity to sign. And when it comes to advanced care plans, we have a third option for signatures. Woody can give verbal consent to digitally execute that ACP. So if he's unable for one reason or another to physically sign, we can select that. We have request for remote signature, or Woody can do the same thing over here. I'll submit that. You'll find that when we need witnesses for documents, we have the same choices. Do you want us to, is that person at the elbow and they're going to grab the iPad or the mouse and just scroll in? Or are they clocked in via telehealth and we're going to send them an SMS or an email? We try to provide as much flexibility to get documents to the point of completion because, again, they're representing a person's communication about themselves as possible. So if I wanted to add the witness, the other thing that we have is if for some reason, some states, not all states, but some states require a wet signature for these documents. Never ideal, but we don't want to make that something that people can't work through. So we do have also the potential to print the witness form, and if a notary is needed, that's also included on there. And then we would fill out Sally and Bob, they would sign, submit, and that ACP would then be completed. Um, the other thing I want to show you before I come back to you all is that we have the ability to upload paper documents. So some folks are fine with what they've already done. Why reinvent the wheel? No problem. We'd go in, we would title that document Woody's Living Will, and then we would check which type of document it is, when it was created, and select the file to upload, and then that file will be available, and that's what would show up in the AD Vault Exchange for query at the point of care. As I'm looking back at my slides, there's really nothing much more that from those that I would want to share that you need the slides for. I feel very strongly that states taking a holistic approach across payers, across technology, across providers, and across patients to say these documents reflect a human being's values and directives. When you have a whole state pulling all of those threads in the same direction, it can completely change what's happening for people at the end of life. And there will be wins on that on the financial front. There will be wins for that on the quality improvement front. But fundamentally, it changes the quality of life and death for people that live in your area. As we help states with these initiatives, I throw my support in from the clinical side. Our marketing department throws in patient toolkits that can be shared across the state. I help set up webinars if that's needed for organizations that maybe they don't have an ACP program and their leadership wants to know how do we stand up a program? How do we not just have technology, but design work to go with the technology? In my view, this statewide initiative is maybe the best chance that we have at bringing the promise home for the people that live in this country and the people that live in your state. As you're considering that, like I said, the technology infrastructure is already in place. What it takes is the energy and the passion to find your colleagues who will say, yeah, me too, I care about that. To identify and network with those folks to say, okay, if you and I both care about it, who else needs to care about it? And Jeanette, you all have done a fantastic job pulling stakeholders into this call. That's phenomenal because y'all folks on this call are exactly the type of network and power that it would take to move the needle to figure out how do we pay for it? Everything in healthcare has to be funded. How do we think through that? Where does the information go? Where does it start? Where does it stop? So the call to action here is to keep the conversation going, to figure out, call up some of the folks we work with and ask them, what's that like? How can this work? Do we have a new innovation that MyDirectives hasn't thought of or hasn't experienced with another state? Strategize how the alignment of efforts and funding and education and engagement will go, and stay in touch with us. Because I think, well, we'd love to work with you. Frankly, I'm signing up to come visit if you all need an on-site visit, because of course I'm sure everybody signs up for that. But that is my presentation for the day. I would love to field any questions, thoughts, insights, concerns that you may have.
Well, thank you very much, Jessica. There was one question in the chat that Mike started to answer. So Kristen asked, if the patient signs a POLST on the platform, how is the physician signature handled? I see you can choose the provider so that they receive an email. Apologies if I missed that. And then Mike said, if the physician is creating the POLST, they can electronically sign on the document. If a POLST is being created by a nurse, I'm assuming, or someone who cannot sign it, then they can select a physician to review and sign the document. The physician will receive a notification to review and sign. And in Hawaii, we can have PAs, APRNs, and physicians. So please answer.
That's an important part of what Mike's team has built for our infrastructure. We're able to protect the scope of license of the individual person signing in. So, I work with a palliative care group that 9 palliative care APRNs in 25 states. They can sign in one state, but not the next. So our infrastructure protects the scope of their license and their practice as they're transitioning between states. And we're able to do that within our infrastructure as well when you're looking multidisciplinary. So if a PA can sign, an RN or a social worker can't, no problem. We are able to identify from the information we pull over what privileges to give to that individual.
Also, as people are thinking, like Jessica said, if there's interest in this, then as a state, we need to look and see, how do we fund this? How can we move forward with it? As we know, funding is tight, but on the other hand, this is a really, really important gap that we have. So Melissa is saying, is this an app or platform that an individual signs up for and pays? How is it financed, consumer directed or health plan directed?
The patient side of this is always free. There are enough hurdles in America to creating your advanced care plan. We don't want money to be a part of that. So the primary source of funding for us is there are a couple of sources, but the application for clinicians, MyDirectives for clinicians, we have licenses to purchase to use that tool. And that scales in different ways that Joanne and Mike are much smarter than I am about as we look at an individual or a small office versus a large health system versus a state. But the consumer side, there's no charge for using. I see Kristen has a question about sign up to get those notifications. So Kristen, the way that you have the list of providers is often we'll set that person, it's basically through an office location. So if you are working as a community social worker under the umbrella of a provider, that provider would also have to have a license to MyDirectives, and we would set you up as in the same office, and then you would select that provider for the signature.
Good. And can you again, we have a number of people from our HHIE, the Hawaii Health Information Exchange. How does how does this interface happen? Can you talk about, you mentioned some other states have this.
Mike.
Thank you,
Yeah,
Mike.
happy to. So yeah, I mean, obviously, you guys have gotten a ton of information today, both from a clinical perspective, a consumer perspective, and for HIEs in particular, in our statewide ecosystem, we really try to make the HIE kind of the hub of the whole program, because most of the time HIEs have hospital systems that are members that are able to access or query and retrieve various types of information on patients in the system. So usually from an HIE perspective, the very first thing that we're doing is integrating the AD Vault Exchange with the HIE so that we can share data between the two platforms. And a lot of times that involves integrating with our query and retrieval APIs that we have. We also have some instances where we do document insertion API integration, meaning if you have documents in your system or your health systems have documents that they want to pass through the HIE to put into the registry, we can support that process as well. And in other instances, we've actually even gone in and integrated MyDirectives for clinicians inside of your physician portal in the HIE so that if they don't have access to it from within their EHRs, if they have credentials to log into your um, clinician portal, that they can still click on a button to launch My Directives for clinicians and do work in that platform from there. So lots of options. We just need to kind of figure out what the blueprint is going to be for the HIE. But most of the time, when we're working directly with HIEs, we're talking about integrating the data points and the documents. I can say that for CRISP, which is a big user that we've been working with for a very long time, anytime we get a record for a resident in one of the states that they provide services for, we actually seed the CRISP system and let them know that, hey, we've got a record for a patient or a resident in your state, and we give them what we call a document reference URL. So we don't send the document to them because we do want to make sure that anytime somebody's generating a query for a patient, they're always coming to retrieve the latest version. But we do give them a unique link for each resident that says, here's where you go to get the latest version of these documents. So if anybody generates a query in the clinician portal for that resident, you already know that there's a record on file, so you can make a call to us and retrieve those documents. So again, lots of different opportunities to integrate at the HIE level.
And on the HIE, I know that I saw a couple of folks that are with the HIE. Mike and I will be at Civitas this weekend. So if any of you all are going to be there, please let us know. We'd love to talk because then you can get inside Mike's rather generous brain of IT knowledge much more
Well,
closely.
and yeah, we did a pretty light demo of My Directives for clinicians, so there's lots more to look at in
Yeah.
that application in terms of features and functions. So yeah, if anybody's going to be in Anaheim, California over the weekend, like Jessica said, we will both be there at the Civitas conference. So would love to meet face to face with anyone that may be going.
I
Yeah,
see.
and I heard that was another offer then, Mike, if people who are interested enough that they want to see the next round of demonstration, then it sounds like that's something you're up for.
Absolutely.
Then Melissa had asked this question about data. Can you program data? There's obviously data can be huge, but can you talk a little to that? And I was thinking about that too for the age-friendly health systems, which I know a number of people are going to do. And how does that fit in? How does the data piece?
Well, Joanne did a great job mentioning that we can provide that time trail if, to support the CPT codes. And really, I think that's kind of the easiest thing to measure. When you're talking about quality measures, the more high quality they are, the harder they are to capture. However, we have a partner who has done a phenomenal job tying advanced care planning sequelae or consequences good consequences to the actual intervention of advanced care planning. They've been able to demonstrate the cost savings per member per month by HCC code for individuals who have ACP versus those who don't. What we provide to you is enough data to be able to see how are documents being created, what portion of your population has documents. We can even tell you who's viewing them. So this same organization, they set up a metric for their ER providers that their ER doctors had to look at a portable medical order for any patient that came in the ER that was over 75 and had an emergency scale of 1 or 2, so very sick. Um, and then those doctors don't get their quarterly bonus if they don't look at those portable medical orders at a certain rate. Well, the way that they are able to figure that out is we keep such detailed data on who is looking at, down to even who is looking at documents, that we're able to send that information back to them. So you can, one, measure follow through on documents existing, knowing that those documents existing, that hospital system will be able to say, and in this population that was 75 and ESI 1 or 2, we can say that those who had POLST did not die in the hospital or some other metric. So the quality measures about inpatient mortality, about length of stay, about readmissions, all of those can be tied when you take our data, match it up with your own. It's retrospective, but you're able to tie our data to yours that'll be in your Epic system or whatever your EHR is, and then start actually building out the case for how ACP is changing the story and improving the quality of care for your organization. And that's reflected in the first slide I showed with those kind of bouncing balls of numbers. We're starting to see data at the national level proving what we've all instinctively known ACP should function to do. But in my view, when you look at ACP, research from about 4 or 5 years ago, it was kind of a negative tone. But also, if you look at that same research, it was conceptualizing ACP as a document, not a conversation, not the quality that went into the conversation, and certainly nothing about what happened to that document after that conversation. We're providing as much cushion as we can around the document while also trying to build maybe the first truly viable path for universal retrieval of those documents. And that could lead to some pretty cool metrics and measures.
So are there, I'm also looking at the questions that Clarissa sent before from the HHIE. So thank you, Clarissa. It's interesting. So if we're saying a lot of our providers use Epic, are there any regulatory barriers about going across systems? Like, what do we need to think about here on a statewide level?
So one I want to reference, I saw just out of the corner of my eye, I think Michelle raised her hand briefly. No, there aren't regulatory barriers. One of the things that I need to do, and I have to do this state by state often in the moment because regulations change and statutes change, and there's a lot of states and districts. I need to get more familiar with what your regulations are around your witnessing requirements. That happens to be the most complicated part of designing solutions. And it's just almost like I tell people we've got 51 states in a district, and somehow there's like 56 different ways to do things. So um, there's not a problem working across Epic. In fact, our CEO got to participate in an event called Unblocking Healthcare IT or something like that recently. There's a major push in healthcare IT to finally start holding people accountable for safe and secure healthcare data sharing because we know it causes risks to patients. Every transition of care, a little bit of data is lost. Maybe we lost one of their meds, or with my patient, we lost their DNR, or something is lost everywhere you look. And so the notion that HIEs have to be functional, that data needs to be going into those spaces and data needs to be queried from those spaces. We're working within those same pathways with MyDirectives. Michelle,
Great. Michelle, did you have a question?
Yes, I
Just
do have a
unmute
couple of
yourself.
questions, but you answered them.
Good.
That was excellent. Love it. Um, so I'm Michelle. I'm a nurse. I'm an ACP coordinator at Hawaii Pacific Health that has the 4 hospitals. Um, I think this question is more for Jeanette and Hope about the electronic provider signature, because currently we don't do for us at HPH, we do the providers sign their own pulse when discussing with the patient. We don't do the electronic version. So that's a more Jeanette and Hope.
Mm.
What's her?
Well, I'd like to hear what Jessica has to say about that because, during the pandemic, other things were possible, and then now we've gone backwards. So obviously, if there's ways to make it easier, and so Jessica, what have you seen with that?
well, I haven't actually encountered that one, but I can say when I was doing the demo, you saw that my signature, which I built when I built my profile, was automatically added. That's a nice
Mm,
little 1.5 seconds of savings. We can actually turn that feature off so that a provider, if an organization feels that that is more consistent with some sort of regulation, that provider would then have to electronically sign every single time.
mm,
Um, I I'm at war with myself. Part of the geek in me is like, but why?
Yeah, move
And the other
forward.
part, yeah, the other part of me is like, I just need to let you know that that's possible. So that's where I'm going to stop. But that's what's possible. We
Well,
do
it's a
think,
yeah.
we do think like, what is it about the signature of wet signing? Are you wanting only a wet signature? If you're only wanting a wet signature over the hand motion, then we've provided you with the opportunity to do the digital completion, then you would print out the incomplete form. What we have found is that many of those documents don't make it into the system. And I
mhm,
actually had Randy, my colleague who's also on this call, I had her do some data analysis on that. For one organization across 2 years of data, we had dozens of patients who had do not resuscitate wishes expressed, but they weren't completed. So those documents were not being returned to the point of care. It's not to say it's impossible. It's just about designing the workflows that feel cohesive with what you're trying to protect, but also align with the efficiency that's available with the technology.
Michelle, would you have a problem with electronic signatures for providers?
No, I think like any processes, and in terms of the documentation, you want to make sure who's signing it, it's validated. It is the patient signing it if the patient has capacity, or their legal authorized representative and not somebody else. But that's
Mhm.
a discussion that's telehealth, whether you're doing it together. So those things are very important, right? And
I
not just doing it. Yeah, go ahead.
No, that I appreciate that. For some reason, I thought that I was hearing from you that the providers didn't want to sign the provider's signature. So one of the things that we've found.
Electronically, just talking about the electronic part.
Yeah, and you're
Yeah.
talking about the patient's signature electronically. So if that's happening in a facilitated setting, consider that they've already made it through 2 unique patient identifiers before they even got to the facilitated conversation. So if you're going above and beyond what the state requires of you, there might be an opportunity to evaluate and assess that. If it's what the state requires, then, well, we'll work with you. We've actually got the state of Maryland is like kind of the most fantastic when it comes to electronic signatures because they saw ahead of time what was coming with digital capacity. And they actually made it possible to say, okay, this individual has their IP address attached to the metadata. We know their email, they've put in their phone number, they've put in their personal demographics, they've gone through all of these things. We're going to rely on that's good enough that they shouldn't also have to find 2 people who can be witnesses. And especially in a clinically facilitated setting, by the time they're sitting with that facilitator, they've been verified and validated through their driver's license and all kinds of forms of identity, plus their identity proofed in Epic to have a record in Epic.
Mm.
We're going to say, good enough. That individual can sign.
I have another question.
Sorry.
I know there's
Keep going, Michelle.
So once those, for example, the patient's advance directive is uploaded from them, who validates it, and then when it comes to us on the healthcare side, can we just download it and scan it into how Epic has their
Mhm.
ACP documents, has ACP documents. So that's the process.
Right now, we don't provide, because we're a tiny team and we're trying to stay affordable, y'all. We don't provide document validation. We do have work streams that are possible to set up for folks, like if your HIM department, they could have a
Right.
queue. So, and it's also one of the reasons that it's preferable to do it digitally, because we have set rules so that an individual cannot complete an incomplete. It's not possible digitally to send through an incongruent or an incomplete document. So
Okay,
when they're
good.
done digitally, you don't have to look at them. But if it's a paper upload, then that can be sent to a queue for a quality review before it's pushed forward. Now, when we integrate with your Epic, and if it gets much more technical than this, I'm going to kick it back to Mike. Some systems that we have integrated with Epic, they want us to push the documents back to media, and some systems don't.
Old school.
Yeah. So it's not something, Epic does not make that fairly very easy. That is one place where all of their robust advanced technology is. So the process to set up document write back with Epic is actually much more strenuous than turning on our application and
Gotcha.
centering it in the right place in the app. So what some of our Epic organizations have said is that's too much. You know, they're going to be paying their IT department a lot to just set that up. So they're training all of their clinicians, don't look at Epic. We've sent flags so that the code status will let that provider know has ACP docs, like it already does, right? But then they know, because that link is right there, don't go to Media Manager, go straight to MyDirectives. I'll see the latest. It's also where I'll create a new one if the patient says this doesn't reflect them anymore. So it's about workflows when it comes to Epic and solving for the document write back portion.
Yeah. And I saw you had the notary upload, which is good because
Mhm.
we have the choice of notary. Last question. The first responders, what education is going out to them? The
So the right now the state that is doing this like in the most progressive way is Massachusetts. And they have set up a really elegant design for their project. And it is, I will tell you, it's only about POLST. Now, I personally, being an ACP geek, think there's some lost opportunities there, but that's what the state mandated, so that's what got funded. And they wrapped EMS in on that. So EMS has sat in on the work groups that design the structure. EMS is sitting in on the work groups that are designing the education. EMS will be receiving the education as that plan is rolled out. I don't have the full plan yet. So it's kind of in development. This whole state initiative thing, y'all, is still really fresh and so forward thinking that pretty much every state that says yes, please, is going to get to design it to fit that state. There's not a cookie cutter mold yet. We know some things that work, but every state so far has proven to be unique and unto itself.
Thanks so much. I had a patient yesterday who didn't. We've had two MyDirectives that's come through our system,
Oh,
and
wow.
yeah, and then one was not. Yesterday, I had a patient who had his medic alert QR code, so there was another avenue of digital stuff. So I was like,
Yeah.
and he's like, asking me all these questions about the EMR and will they follow it and things like that. So very similar. So
I think that's a pretty good use case example for the simplicity of having one system to organize it all. You know, when it takes out some of those questions, and there's um, one of the things that's also possible when you do these healthcare ecosystems is not just the clinical shift, but also thinking about it's not this health system teaching about ACP to its community this way and this talking to its community this way. You've got all of the players and the payers, because payers are also interested in all those pretty bouncing balls that I showed at the beginning. You've got them also on board, and then you've got education happening at the community level in a much more consistent way. And people are receiving the same locations to go to, the same information about how this impacts their power in their healthcare. Jeanette, you're on mute.
One question from Jackie. When you do look backs at compliance with advanced directives and POLST, are you tracking people that have these documents and they do not get followed? or just the ones that do not have it and it leads to an adverse cascade of intervention? Is this something you're tracking with your KPI? What is a
We
KPI?
Key performance indicator.
Oh yeah. Okay, good. Thank you.
And right now, we don't have visibility to track those KPIs. Now, we feel very strongly that those are the right KPIs to be tracking. So what we have done, and this is largely, again, Randy, my colleague that's on the call, she's our quality director, and she's really good with data and analysis. So she's found the ways to present the data so that you can butt it up. What we do is we basically insert ourselves into your system without receiving back data. So that patient that has that ACP, all we know about them is their ACP. We don't know anything else about their blood pressure, their diagnosis codes, their living, their dying, or anything. So right now, the information is pushed to you to be able to do that analysis to see how is this performing those outcomes. And like I said, I've got organizations that I'm working with that can present best practices. They're working on publishing that right now, and I can't wait till they do, because then I'll be like, here, just read this. Because I can't describe to you the 5 years of work that brought them to the point where they're able to be like, look at this, guys, this matters. But building the program for them, and that was before they came on board with MyDirectives, and iterating it and adjusting it and shifting it. And then as we came in to be their technology solution, it just has blossomed with what they're able to do and the amount of documents they're able to create, and then the details and the data they're able to follow through on.
Jessica, all being said, I would love to be able to partner with a organization where we can provide those clinical indicators of those decisions around CPR and life-sustaining treatment, and partner with them to do that analysis. I would love to be able to do that work with an organization and kind of dig into the dirty details of it.
That's Randy, our Director of Quality and Clinical Implementations, folks.
Good. I was just checking. Who is that? Okay.
I've been a fly on the wall.
No, we're so glad that you're here, Randy. Randy Hirschman. I wasn't sure who you were. Anyway, I am so grateful for all of this time. Kind of last call on questions or comments, although I hope that people will send me a note if they want to keep talking about this. Personally, I'm really interested in this. Dr. Fishberg and I have been looking at this back before the HHIE was created. We always think, what about a POLST registry? Jessica was very polite. Other states have tried things that were disastrous, and I am very glad we did not. So, however, maybe this is a way to help our state, especially, I'm thinking especially in rural areas or people who may not just be in one place, that this can really be helping. So I hope that people can drop me a note if you want to keep talking. I'm really interested in Mike doing, 2.0, so we can see what else is out there. And I really I appreciate the range of people that came today, end users and also the people up at the beginning. So I really thank you. So I don't see any more questions. So Jessica, thank you so much for this talk today. To clarify, we are going to we've recorded this. It will be edited. We'll put it up on the Kōkua Mau website. Hopefully you can share it with colleagues who weren't able to come today. So thank you very much to Jessica and the whole MyDirectives team for coming and sharing with us. This is really interesting, and I really hope this is just the beginning of collaboration. So thank you very much for coming.
Thank you all. I appreciate your time.